everybody. You're very welcome. We just give everybody a few minutes to arrive, and then we will begin this webinar. Okay, I think we have quite a few people already that joined us on time, so I suggest that we get started, and we can always welcome them as they come along. So good afternoon, everybody, and welcome to this webinar today. And I'm really delighted to introduce Professor Michelle Leach. So for those of you that don't know her, Professor Leach is a professor in radiation therapy. He had a discipline of radiation therapy at Trinity College Dublin, and she's a current course director for the BSc Radiation Therapy in Trinity. Professor Leach is known internationally for her advocacy for radiation therapy and for radiation therapists, and she has received several national and international prizes recognizing her contribution to education in radiation oncology, and this includes the prestigious Van der Schoen Award from the European Society for Radiotherapy and Oncology. Professor Leach is very research active, and her research is focused on improving radiotherapy outcome for patients, and she is leading many international projects. But today she will specifically speak to us about the work she's doing with Radiomics and explain how this technology could improve patient stratification and help optimize radiation therapy treatment. So when you're ready, thank you very much. We're delighted to have you here today, and we look forward to your talk.
Great. Well, thank you very much, Laura. I'm just going to check, first of all, that which screen you're seeing here. Just stop for a minute. One moment. Desktop 2. Okay, that should be it. Yeah, okay. So you're seeing the right screen, I think.
Yes, so if you go, if you go to presenter mode. Yeah, perfect. Thank you.
All good. Okay, great. Well, thanks very much, Laura, for a very nice introduction. I'm delighted to speak today about a topic very close to my heart, which is radiomics, and talk a little bit about the potential of radiomics in cancer care, how I see it, and also to talk a little bit about some projects that I've been involved in, and also Laura has been involved in some of them with me as well. So just to begin, I guess, for those of you who are not, I'm aware a lot of people are not familiar with the term radiomics or radiomics. Sorry for my Irish accent, I say radiomics. So radiomics is a quantitative method of basically analyzing images in its simplest form. And what we can do when we analyze those images is that basically we can extract essentially what are image biomarkers known as features. And when we extract those features typically mean something, or they're linked to something. So that they're linked to some outcome. Okay, so that can be a tumor phenotype. It can be a clinical outcome. It can be hypoxia. We'll see in a while. So they're basically a marker of something, essentially. And this paper that I'm showing you here is really, I suppose, one of the seminal papers in radiomics research to date. And probably the two global leaders in radiomics research are Aerts and Lamban that you see here on this paper. And what they essentially did was that they took the CTs of over 1,000 patients who had either lung or head and neck cancer. And from that, they were able to extract 440 features, so of these imaging features, just directly from their CTs. And what these features, I suppose, what do they encapsulate? So they encapsulate things like image intensity, shape, and textural analysis. And what they actually found was really quite groundbreaking at the time, because they found that a large number of these features actually had an ability, a prognostic ability to basically say who was going to basically do well in their treatment and those who are not. And that never really existed before. And I think that was a really, I suppose, quite an important turning point for us, particularly in radiation therapy, when we have so many images all of the time, and we routinely take so many images, pre-treatment images and on-treatment images, and also, of course, there's follow-up images. And we have all of these images, but, you know, do we actually, I suppose, optimize them? And so I guess for me, what I see radiomics as being is really a method of us to improve our decision support in cancer treatment at quite a low cost, because of course we're always taking these images anyhow as part of the patient management. So after that seminal paper, there was this kind of explosion in radiomics research. And since 2014, if you do a quick PubMed or whatever MB search, you'll find thousands of publications. And the publications really, I suppose, look at a lot of different areas. They look at, as we said, clinical factors, outcome prediction, screening of patients and stratification of patients. And then something called delta radiomics, which is quite interesting. So delta being the Greek delta, meaning change. So for example, looking at how people maybe react to treatment, and should treatment be adapted at certain stages. And now we see a lot of papers actually going beyond oncology, but typically moving into things like neurological conditions. So I guess the first thing to talk about in radiomics is that it's quite a defined process, I suppose we can put it like that, which suits us, of course, in radiation therapy. And the first thing really that you have to consider is the definition of the radiomics pipeline. And this is what we did in this publication. So I guess there's really, I suppose, 5 different areas that we can talk about when it comes to the radiomics pipeline. And the first one, and we'll talk about them in different one by one, but the first one is the image acquisition, which sounds like it's straightforward, but as we'll see, it's not necessarily that straightforward, because everyone does slightly different things, or sometimes quite significantly different things to one another. And then you have to decide, well, what is the, you know, you have a full MR or a full CT data set, but what are you actually interested in? What are you actually interested in extracting these features from? You're not going to extract the features from an entire data set. I mean, you know, it's kind of meaningless. So the region of interest delineation becomes extremely important, or what are we actually, what's under investigation here? And then once you've defined that, which again, as we'll see, is not always that straightforward, then of course you come to the feature extraction. So what features are you going to extract, and what are they going to actually represent? And then you can do something quite interesting, which is that, whoops, sorry, a very sensitive mouse here. Then you can do something quite interesting, which is that, of course, you can have the features on their own, or you can integrate the features as kind of new data into maybe a model that already exists, or clinical data or molecular data or pathological data that you already have. And that kind of enhances, to see if it will enhance your model or your algorithm to make your decisions about treatment. And then finally, of course, what we're really interested in all research is actually bringing it into clinical utility. So I suppose if we look at the first step in that pipeline, which is image acquisition, and I'm sure for this audience, looking at some of the names of people who are in the audience, I don't have to tell you about that. Image acquisition is rarely standardized. And of course, there's many options open to radiation therapists, radiographers, when we're acquiring images at CT, MR, or at cone beams for radiation therapists at the LINAC. And so there's loads of different things. Of course, there's lots of things that we can change, okay? So things like fields of view, MAS, KBP, slice thickness, if it's an MR, what's the field strength, the voxel size, and so on and so forth. So one of the main issues, if you're extracting features or imaging biomarkers from an image, is that you want to make sure that what you're extracting is actually, you know, of interest or representative of that region of interest, and that it's not just, you know, noise, essentially, that is in the image because, you know, someone decided to use, you know, some image acquisition parameters that really were not optimal. And then, you know, if I performing an analysis here on MRs that were taken here in Dublin, and then I'm linking up with a colleague in Paris, for example, you know, are our imaging protocols going to be the same? Do we have the same equipment? So there's quite a lot of questions about this. And one thing I suppose we have to be realistic, as we always are in radiation therapy, is that we're not going to have universal imaging protocols. Wouldn't life be wonderful if we did and everyone did the same thing? But that actually is not how it is. And of course, that gives us our first I suppose, main area of research in radiomics, which is trying to work out what we call robust feature analysis. So what are, I suppose, the features that are robust to these changes, these inevitable changes in different image protocol settings, and also moving to the second step in the pipeline, also region of interest delineation. So I suppose some of the things to talk about in image pre-processing is that if you are going to build a model, so any model, if you think back to your days in mathematics, or maybe some of you are still working in mathematics, you know, a model is only as good as how repeatable and reproducible it is. Okay, so, you know, we need to have something that's going to be useful in the clinic across different jurisdictions, for example, but also that you know, it's actually sound, okay, and that it's kind of methodologically sound. So if we're going to use these for prediction, especially, we need to make sure that they are repeatable and reproducible. So if we stop and we think maybe, for example, about MR images, just as an example, you know, MR image intensities are going to vary depending on quite a lot of factors, aren't they? So things like voxel size, what's the pulse sequence, even the vendor and the different types of MR and the reconstruction algorithm. So the issue, I suppose, when you extract radiomic textural features from a region of interest, and textural features are features that describe basically the pattern of distribution of voxels, and in that way kind of measure intratumor heterogeneity. If you basically you use different quantization methods, these values change. Okay, so you need to basically do something to stop that from happening, or otherwise you're not going to be able to build a radiomics model that is, as we said earlier, repeatable and reproducible. So feature extraction, I suppose, also gets a little bit slightly more complicated by not just the imaging parameters and pre-processing, but also by noise, random noise in images, as we know exists. And that noise in images alters not just the image metrics, but it actually can change the relationship between the voxels. And noise is very different between different manufacturers of MRs, again, scanners, and different institutions. So one thing that we can do to get rid of image noise, and we know we can do it, is resampling of the voxels. Okay, so essentially bringing the voxels, if you like, kind of aligning the voxels, I suppose, from different images. And then the next thing that we can do is normalize the images. And normalization in radiomics is kind of different from, so I'm just using MR as an example here. It's a little bit different from MR and CT, obviously, because of, you know, in CT we have Hounsfield units and we have electron densities, and of course we have arbitrary units in MRs. But as an example, in MR, normalization basically corrects this non-parametric intensity non-uniformity. And if you like, it kind of aligns and brings the grade level analysis into a range that's manageable. So typically plus or minus 3 standard deviations. And then the last thing, I suppose, feature or last parameter that's open to us to kind of work on this pre-feature extraction are things called interpolation algorithms. And interpolation algorithms basically translate image intensities from their original image grid. So if you like the raw data from the image to this interpolation grid, again, kind of aligning, if you like, the images, where voxels are spatially represented by their centers. So that's just a little bit, I suppose, of the background about some of the issues when it comes to image acquisition for radiomics analysis. So it's not as simple as we're going to have, you know, a multi-center study. We're all going to just, you know, submit our data and off we go. You know, there's quite a lot of pre-processing that has to be considered on images. Then I've touched on this a little bit already. I'm not going to talk about it too much today because I think that particularly those who are in radiation therapy, we know quite a lot about inter-observer variation when we're defining regions of interest for feature extraction. But that is an issue that has to be considered when we're looking at what features we're actually going to extract. I mean, there's no point in extracting features from a region of interest that's incorrectly defined, obviously enough. So that is something that also has to be considered, particularly in multi-center radiomic studies, about how have these regions of interest being defined? Have they been defined with some automated methods? Has there been some kind of analysis of intra-observer variation. Are there features that are robust to different people delineating on the same data set, for example? So there's quite a lot of issues about the region of interest delineation too, and I'll come back to that a little bit in one of our own studies later on. Okay, so we've now discussed a little bit about A and we've discussed a little bit about B. So now we'll talk a little bit about what happens with these features. And we'll talk particularly, I suppose, about some specific examples. Yeah, so that brings us to our second area of research, which is the actual feature extraction and what are you going to do with these features and are they any use to us in cancer care? So that is, I suppose, can be encompassed under a heading of modeling and predicting clinical outcomes to aid treatment decision making. So what can you model? You know, so of course you can, you know, you've all heard the phrase lies, what is it, lies, damn lies and statistics. So of course you can model anything, but you want to make sure that you model something that actually is going to be of clinical use and is well defined. And I suppose that's that kind of well defined clinical outcome is actually probably the most important aspect. And having very good outcome data, okay, when you're going to perform a radiomics analysis. It's not good enough to essentially have, you know, very nice images, but you really have to have, you know, the outcome data that you're going to model. It needs to be very, very well defined and documented. So what can you model then? Obviously, a well-defined clinical outcome, and I'm going to give you an example of hypoxia. And I suppose what the beauty of radiomics is that you're analyzing it in a non-invasive manner. And if we take an example of hypoxia, you know, typically before a lot of the hypoxia measurements, you know, were quite invasive in patients, and this potentially could be a way of looking at hypoxia in a non-invasive manner and adapting your treatment accordingly. Because as we know, particularly in radiation therapy, hypoxia is kind of our enemy in terms of treatment outcome. Another thing that you can model is when you want to measure and subsequently predict a change in response following an intervention. So following, say, for example, X number of fractions of radiotherapy, and then you want to act upon it. So say, for example, do you want to intensify treatment? Do you want to de-escalate treatment to prevent toxicity in patients? And that, as I mentioned before, is called delta radiomics. And then the third one is really when you want to kind of separate out your patients, say, for example, at the start, based on risk. So things like human papilloma virus status, or an example I'm going to give again later on is the likelihood of developing aggressive prostate cancer, which is a project we're working on at the moment. So let's take a look at some of those. And the first example I gave you there was the hypoxia example. And this is work that Laura and I completed with Heidi Ling and Tord Humpland's group in Norway. And so what we did in this study was that we essentially took data of a study that Heidi's group had already completed called the FUNCT-PROST study. And what we had was we essentially had 88 intermediate or high risk prostate cancer patients, and they'd had multiparametric MRI, and we took their T2 weighted MRIs. And all patients prior to having surgery, so these were surgical specimens, as you'll see in a while, all these patients had received the hypoxia marker called pimonidazole, or PIMO for short, 24 hours prior to radical prostatectomy. And then PIMO hypoxic scores were basically assigned by an experienced pathologist based on who was, blinded to the MRI, so that's quite important. And 165 features were basically extracted by us from the region of interest, which the radiologist had defined on the T2 weighted MRI using the pathological specimens. Okay, so I guess the one thing to point out here is that even though prostate cancer is obviously a multifocal disease, we focused for the region of interest specifically on the index tumor. So the largest, I suppose, or the primary site of cancer for the men with prostate cancer. So we modeled hypoxia then as PIMO less than 3, a score of 3, so it goes up to basically 5, score of 5. Less than 3 is not being hypoxic, and PIMO greater than or equal to 3 as being hypoxic. And so what did we find? So I suppose this is a bit wordy here at the start, but essentially when we performed the multivariable logistic regression, and we performed tenfold cross-validation to basically find out, well, was this predictive, were these features that we extracted predictive of hypoxia or not? And we standardized all the features before modeling. So we've done all the pre-processing and things that we talked about earlier as well. So what we essentially found at the end was 6 different features basically that came to light in the model when we created it. And what we found were that these shape features were actually the most important. It wasn't wonderful, I have to say. I mean, our area under the curve was 0.6. So if you think that 0.5 is a random chance, it wasn't significantly higher than that. But, you know, it led us, I suppose, to think that perhaps there might be something there in the future, keeping in mind that we had also just decided to use the index lesion as a region of interest. So, you know, had we decided to use the entire prostate, maybe we would have got a different result. Who knows? So another example that I wanted to give you was a project that I was involved in with some colleagues here from Ireland, Professor Charles Gillam, who provided some data for this project. And this was a HPV cross-validation study across different cancer sites in Europe. And essentially, this group in Belgium had already validated CT-based, so this time we're moving to CT, CT-based radiomics signature to predict HPV status, which was, I suppose, defined in terms of that clinical outcome by P16 as a surrogate, which, as you know, is quite common in head and neck cancer. It was developed in head and neck cancer, and we wanted to validate it in anal cancer patients. So, as you know, HPV is indicated in a number of different cancer sites, head and neck, anal, and vulvar in particular. So 68 anal cancer patients that had P16 status were determined by immunohistochemistry. The control cohort might look a little bit strange, but the control cohort were lung cancer patients. And the reason that they were lung cancer patients was that, you know, we know what the expected European prevalence of HPV is in patients with lung cancer, which is somewhere between 0 and 10%. And what we found here was that we found 1%. So so that's I suppose gives us comfort that the control was working. And the signature classified anal canal cancers based on their HPV status would have a pretty good AUC of 0.76. So the original signature had been developed in oropharyngeal squamous cell carcinomas, and that AUC was 0.764. So it was pretty close to what had been found in oropharyngeal cases. And then the next study that I want to talk a little bit about is one that we're working on at the moment. And this is the prediction of advanced prostate cancer. And this is funded by the World Cancer Research Fund and colleagues from Queen's University in Belfast. You see here Emma Aulett and some colleagues from the University of Bristol are also working on this project. And the hypothesis is, I suppose one thing I have to say first is for the radiotherapy audience is that this is not a radiotherapy project, which, you know, is, I suppose we're all stepping a little bit out of our comfort zone on this one. And the hypothesis is that this fat depot around the prostate, known as periprostatic adipose tissue, or PPAT for short, is associated with an increased risk of advanced or fatal prostate cancer. And so there's 3 aims of this project. The first is to describe the distribution and etiology of PPAT in cancer-free men. The second, which is the part that our group is working on, is to examine the association between PPAT and the risk of advanced prostate cancer using radiomics analysis. And then the last part is performing a GWAS study, essentially, to assess the causal role of PPAT in advanced prostate cancer. So focusing on our part of the study, which is the one in bold there in the radiomics analysis, Now it's time to bring in my two colleagues who I believe are in the audience, who is Dr. Angela O'Neill here on the left and Ryan O'Keefe. Angela is a research fellow here in our group, and Ryan is a research assistant. And so thanks to them, because let's be honest, they're doing most of the work on this project. And at the moment, they're defining and quantifying the PPAT. So the first thing I should tell you about is the databases that we're using for this project. So because our colleagues are going to be performing a GWAS study, we need very, very high patient numbers. So therefore, we are using the UK Biobank MRI scans, which is a little bit challenging, as we'll see from some of the images later on. But that allows us to have essentially of 28,000 scans, which is obviously a very high number. We also are working with a group in Iceland on an AGES study, which is a longitudinal study in Iceland that has been going on for a very long period of time, more than 50 years. And they have longitudinal health data, including scans, CT scans of their population, essentially. And they're providing us with those data and the CT scans. As I said, it's important to know that these are cancer-free males that we're looking at. We're using 3D Slicer at the moment, but Ryan and Angela are very busily starting to prepare an NNUNet-based model to scale up this delineation, because obviously we're not going to manually delineate 28,000 scans. So we'll initially start with a random sample of 500 males from the UK Biobank and then scale up to 28,000. And I suppose one of the major issues that brings us back to the radiomics pipeline that we have to look at is the definition of the region of interest. And for us, the region of interest is something that, you know, is going to be a little bit out of our comfort zones, because it is PPAT. And not a prostate or rectum that we're used to delineating. And one thing to say about PPAT is that there's massive variation in the methodology in the published literature about how do you actually define PPAT. So there's a lot of issues about what are the anatomical limits, for example. Should it be a 2D measurement? Should it be a 3D measurement? Should there be a manual or automated segmentation? Well, in our case, for the UK Biobank data, it will be automated segmentation once we've trained the model, of course, and a lot of different imaging analysis software use. So there's quite a lot of variation before we ever actually start on the feature extraction. But thanks to Angela and Ryan, this is what we have come up with as the PPAT definition. You're going to see our issue with the image quality from the biobank data on this slide. So, you know, I know the radiation therapists in the audience are gasping a little bit at these images. But the issue that we have on the UK Biobank data is that they're whole body MRs. So Ryan has very cleverly managed to write a script that kind of defines just the pelvic area very neatly for us. But as you can see, that we've quite a significant issue on image quality, which we're going to have to overcome later. But first of all, we're going to define the PPAT. And so I suppose the anatomical borders that have been decided upon at this stage are anteriorly the posterior of the symphysis pubis, posterior anterior of the sacrum, left to right, the most lateral extent of the internal obturator muscle, superiorly the base of the prostate, and inferiorly the apex of the prostate gland. And based on that, this is kind of how it looks. And you can see these are very highly pixelated images, which does cause some issues for us. But what we've decided to do is that we've kind of separated out what we now call the ant PPAT and the post PPAT. So at the moment, we have kind of two regions of interest, if you want to call it that, even though it's anatomically kind of the same structure defined. And the green will be the prostate gland. And yeah, here's quite a nice image that Ryan provided me with. Thank you very much. Showing this in a slightly different way. So this is kind of it's a structure that, you know, in radiotherapy, we don't really think about, you know, but we're very interested in now because of its potential, I suppose, metabolic features that could actually be predictive of advanced prostate cancer. And while not in this project, we're kind of thinking forward to how this is going to maybe affect the radiotherapy pathway. This is a much nicer image that we took from the TCIA, the Cancer Imaging Archive, to help us build the model. But I suppose what's interesting here is that it does show you this kind of the issues that we have in defining anterior PPAT, because it's quite, a bit of a stringy, I suppose, kind of area and kind of highly speculated, which is not that easy to define. So at the moment, just some of the work that Ryan and Angela are doing on this is that they're kind of constantly manually contouring these images. And they basically are checking out their, I suppose, the inter-observer variability, as we mentioned earlier, which is going to be very important when it comes to our radiomics analysis. So we need to have kind of measure that. And what we've basically worked out is that, well, there's no problem, obviously, with Ryan and Angela as former radiation therapists defining the prostate and the rectum. Their DICE coefficients, or the similarity between what they define, is very, very high. The post PPAT is also quite good, but this stringy kind of ant PPAT is what we're still working on at the moment. And we've found kind of different ways of potentially overcoming that in terms of thresholding. So I'm checking my time because I tend to overtalk. But anyway, so I suppose in conclusion today, I've just given you hopefully a bit of a snapshot of what radiomics can do. And maybe if you are working in a radiation oncology department, or you're working in a diagnostic imaging department, to maybe start thinking a little bit, more beyond what we use images for. And of course, if you think about the quantity of on-treatment images that we take in radiation therapy in particular, and we use them for geometric analysis and geometric accuracy, which obviously is extremely important when it comes to precision of therapy. But, is there something else in those images that we could actually start to use them for? So I'd say that radiomics has potential, is how I would put it, in the personalization of cancer care. Modeling outcomes can assist in kind of stratifying your patients. And of course, that's important in radiotherapy in terms of managing toxicity and de-escalating treatment where you can, and intensifying treatment where you need to. But also in that last project that I've presented to you, it can also help us to, in cancer-free individuals, see who is likely to present with advanced cancer, and actually maybe do something about it before the cancer actually presents, and they may need some lifestyle interventions. I would say that for us in radiation therapy practice, radiomics also has potential as a decision support tool for clinicians and patients. So if you think about the nomograms and things that we already use, is there something extra that we can get? I mean, I think it's definitely worth asking the question. And then also, I suppose, as time goes on, moving beyond just geometric adaptation on set of the treatment unit in radiation therapy, because, we know that a tumor shrinkage, doesn't necessarily mean anything biologically. Something that we see geometrically, we shouldn't be led by, particularly because, that it can be a little bit misleading, I suppose we can put it like that. So overall, I think that I would say when you're looking at your images, maybe look at them in a new light, that maybe there's quite a lot of additional data in those images that you haven't thought about before. And that's really what the beauty of radiomics is, and that's what it offers us. So I will stop there, Laura, if that is okay, and I will hand back to you.
Yes, thank you very much, Michelle, for a really nice talk and a very nice overview of the work that you've been doing. So I don't see any questions on the Q&A, but I might just give people a few minutes to type them in if they haven't had a chance during the talk. So you should see a button at the bottom called Q&A. So please type in anything you might want to ask Michelle today.
I realize for people it can be a pretty, sometimes it's quite a new concept, it can be quite a different way of, of thinking about images, particularly for people who are, working in radiation therapy, you know, because we're so
Yeah.
all
Yeah.
consumed with geometric, you know, accuracy all of the time. So it can be a little bit
Yeah.
different. But what I would say to people is that, you know, you have a lot of maybe untapped data in your department, you know, that that could be analyzed in a slightly different way. I'm not saying that it's going to be earth shattering and we're all going to, you know, change how we practice based on radiomics analysis, but you know, it may offer us some extra information that's not there, that hasn't been there previously.
So maybe you can, well, people maybe thinking about pictures. Can you just maybe comment on, you know, how many images will I need to pull out from my data set or my bank to begin to work with radiomics, and yeah, how easy will it be to get started?
Well, I think you know, how many images is kind of is you know, the same as when you're starting any study. How many patients do I need for XYZ? I mean, it depends on what you're trying to do. Sorry, it sounds like a very evasive answer. Sorry, Laura, but it does. It depends on you know, what are the outcomes that you're trying to model. Okay, and then are you going to have, for example, a combine? Are you just having a radiomics only model, or are you having, as I discussed earlier, a model that already incorporates, say, for example, clinical endpoints that you already know about? So, you know, things like stage, T stage, you know, nodal status, pathology, so on and so forth. So, of course, the more variables that you're going to bring into your model, because if you think about it, what are these only kind of very sophisticated logistic regression analysis? I mean, that's what they are. You know, as you're going to require, I suppose, if you're going to run a model or build a model with lots of variables, well, then you're going to have to make sure that, you know, you've accounted for that in your sample size calculation. So, you know, I mean, what we typically say, I mean, I know I talk there about the large study that we have with the prostate cancer patients. It has thousands of patients. I mean, that would be quite unusual in a radiomics analysis. I mean, the main reason why there's 28,000 there is to basically support the GWAS study that's happening at the same time. So I suppose if I had to go out on a limb and give you a ballpark, I mean, I would say, you know, the higher the better, but certainly in the high hundreds if you wanted to make, if you're trying to predict something. The other thing that I haven't mentioned there is that it's extremely important as well that if you build a model on a certain number of patients, that you validate it. Typically, it would be far more preferable to externally validate your model. So if we build a model here in Dublin, it would be much more preferable to validate that on the data set from wherever, you know, somewhere in the Netherlands or in the UK or whatever, a different population that's outside of your own. Because the most important thing of any model, you know, is its generalizability. You know, a model that is, you know, for Irish men in, you know, with prostate cancer, you know, is not particularly useful if we're going to use the model, you know, in Singapore, for example. You know, so you need to make sure that you have an external validation to you know, ease that kind of transition of generalizability.
Yeah, I think the validation step is probably a good one to think about to make sure that what you find can make a difference. But certainly, I think people can kind of, as you said, start thinking about what images they may have access to and what, I suppose, what clinical question they want to ask. Because again, when you develop a model, you need to have a clear idea of what it is you want to actually answer or want to predict. So, you know, I think the danger of radiomics is that I won't say it's easy. It's not easy to get data, but you can get a lot of data very quickly, and it can be very overwhelming to be faced with this amount of information if you don't have a clear idea of what question you want to answer. So maybe that's the first step for people. I see an attendee that has there is one question from so just so you know, your chat is disabled, but you should see a button called Q&A beside it, and that's where you can log on your questions, please, if in case you didn't see it. So the question is, Michelle, do you think radiomics will need to be a core topic in radiotherapy degree courses in the future, or maybe postgraduate?
Oh, that's a tough one, Angela. I don't know. I suppose, sorry, is probably a very honest answer. I mean, I think don't get me started on what should be in radiation therapy curricula. That's a whole other hat that I wear, of course. I mean, I'm not sure about radiomics specifically, but I would say that, you know, as you know, we use quite a lot of automation, obviously, and a lot of AI in its own way in radiotherapy already. And sometimes people get very excited about artificial intelligence and think, oh, you know, what is this and how is it doing this, and so on and so forth. But actually, if you think about in radiotherapy, from pre-treatment all the way to on treatment, we use quite a lot of kind of AI based models anyway in every day in our decision making. So what I would say is, I'm not sure if people need to learn specifically about radiomics as part of, you know, the practice to be a radiation therapist, but probably what, you know, we need to do, which, you know, I think a lot of programs do, is that, you know, elements of AI are kind of incorporated in the program throughout. So not just radiomics, but kind of the whole idea of AI automation, which I think really, if you think about even a module, for example, in image guidance, you know, you're going to have some of that in there. So I would say maybe not specifically radiomics, but certainly elements of AI.
Okay, great, thank you. And then we have a question from Melissa asking, thanks for the nice presentation. Why look at adipose tissue?
Yeah. So the reason, thanks, Melissa, for that question. The reason why we're looking at adipose tissue, or that specific, I suppose, PPAT, which is the adipose tissue around the prostate, is because it's believed to be, I suppose, metabolically very active, in terms of actually, I suppose, the promotion and the sustainability of cancer, of prostate cancer in men. So that's why we're looking at it. So what we're trying to find out is, you know, and it's also, sorry, what we call a modifiable fat depot. So you can actually do something about it with lifestyle choices to try and reduce it. Okay. So if we find, for example, that, you know, and I'm just postulating because we don't know what we're going to find yet, but say, for example, if we find that men who have very high levels of a particular imaging feature in their periprostatic fat are more likely to have advanced prostate cancer, what we're putting forward is that when we have images of men who don't have cancer, who are just having MRIs, and this is noticed, that actually an intervention can happen at that stage to change their lifestyle factors to actually prevent them from going on to develop advanced prostate cancer. So that's why we're looking at that adipose tissue.
Yeah, and I think it's very interesting to think that the fat that we carry could have an impact. It's kind of an interesting concept, and that you can use it with imaging as well. Would be So I don't see any more questions on the chat.
I think I saw Liz had her hand up at one point.
Oh, sorry, I missed that.
I can press allowed to talk. I don't know, Liz, if you're there.
Oh yeah, I'm here. Sorry, I've literally just sent it in the chat. Thanks.
Oh, you put it there. Okay, thank you.
Yeah, sorry.
Okay, yeah.
I was just curious, Michelle, just to get your opinions on, you know, you talked about the requirement to have high quality outcome data for modeling. You know, a lot of the outcomes that you've discussed are really easily quantifiable as well, but what about the outcomes that are more subjective? And do you think that kind of introduces noise that's difficult to handle from a radiomics driven modeling perspective?
I wouldn't say, I don't think it introduces more noise. I mean, I think, you know, I have a pretty good idea about some of the outcomes that you're talking about, but, you know, in terms of subjectivity, I mean, you know, for us, I think the most important part is always in practice is what is the outcome for the patient. So whether that's something quantifiable or that's something that the patient feels, you know, in a subjective manner, you know, who are we to say that it's not important? You know, if someone feels that they have whatever problem with swallowing, or they have dry mouth, or they have, you know, tenesmus, or whatever the side effect is, I think it's more, you know, it's always more challenging if you have a kind of subjective outcome. You know, it's always easier to work with numbers. Let's be honest, at the end of the day, if you have a scoring system 1, 2, 3, 4, 5, you know, you can say your outcome was, as I showed you there on the hypoxia scoring and how we defined hypoxia using PIMO. So I think it's probably a little bit more challenging, but I wouldn't say it adds more noise. And I definitely think it's extremely worthy of investigation, because at the end of the day, with these kind of subjective outcomes. I mean, they're still patient outcomes, and you know, that's actually probably what's much more important than the numbers.
Yeah. Thank you. So you have more. Thank you very much from attendees. If there is no more question, perhaps we can close this session. And thank you again for a very nice presentation and a very good overview of radiomics. And I'm sure everybody is leaving this call with some ideas in their heads as to you know, what perhaps they can explore or read about to begin to use these images in a much more efficient way. And we certainly will welcome people seeking that way, and would like to see more studies in the field. That would be really, really nice. So thank you very much. I wish everybody a lovely afternoon or evening or morning, depending where you are. And I hope you will tune in for our next webinar next month, which will be advertised very soon. And yeah, thank you very much.